Welcome to Fig Medicine. This is a series I've named Board Gems, which I've been meaning to start for a long time now. It's going to be for the USMLE Step 1 and Step 2, as well as the Comlex Level 1 and Level 2. I've chosen subjects for this series that students tend to get tripped up on very frequently due to exam writers being tricky or students just not knowing certain details that they should. And so the first episode today is going to be on rheumatoid arthritis versus osteoarthritis. When it comes to RA, we really want to focus on which joints are involved. And for RA, that's going to be the wrists, MCPs, and PIPs. There's going to be symmetric joint involvement as well as morning stiffness that improves with activity. I'm going to show you pictures in just a second of what these swan neck and boutonniere deformities look like, but these are absolutely crucial for you to know. You're going to see a pannus formation on X-ray, but what is a pannus? A pannus is inflamed granulation tissue because of synovial inflammation, which causes synovial thickening, which will damage the articular cartilage and bone. In RA, you'll frequently see cervical spine involvement, and particularly children with Down syndrome are at increased risk of developing compression of the spinal cord called atlantoaxial instability, which is the atlas C1 over C2, the axis. There are some amine markers here that we have to be aware of. HLA-DR4 and HLA-DR1, those will occasionally come up on Step 1 and Level 1. You'll have to, here's a way to remember it, four windows per one door in a room. That's how I remembered it for Step 1, and that's just stuck for some reason. You might have in a question stem joint aspiration and you'll get inflammatory synovial fluid, but of course they won't tell you outright. They'll give you the white blood cell count of the aspirated fluid and it'll be elevated. That's also another clue towards rheumatoid arthritis. The most specific antibody is anti-CCP. And rheumatoid factor is an IgM antibody against the Fc portion of IgG. Again, this comes up more so on Step 1 than it does on Step 2 and Level 2. And rheumatoid factor forms large complexes that can deposit in tissues, which makes it a type 3 hypersensitivity for that case. Felty syndrome is an associated condition. It's a simple triad, RA plus neutropenia plus splenomegaly, and Kaplan syndrome, which is RA versus plus pneumoconiosis, which is also called smokers pneumoconiosis, or coal workers pneumoconiosis, that's what it's called. So I would just know those two syndromes. And as far as treatments go, DMARDs are going to be the first line, such as methotrexate, and then glucocorticoids, NSAIDs, and leflunomide. What is leflunomide? Leflunomide inhibits T cell proliferation, which makes it especially useful for this because in RA, we have activation of CD4 helper T cells. So the leflunomide will inhibit that T cell proliferation. You just have to remember this is an autoimmune condition. All right. So here's an example of the swan neck deformity. It really looks like a swan neck here. And we have ulnar deviation. Remember, this is the radial aspect of the hand. This is the ulnar aspect. The fingers are going to ulnarly deviate. Here's the pannus, which is the granulation tissue we were talking about earlier. And here's the boutonniere deformity. Right over here, a little bit of histology. This is a palisading granuloma with central fibrinoid necrosis. All right. So I want you to be careful because you might come across a situation where you already know it's RA and you already know what to do next, which is methotrexate, one of those DMARDs, but they'll try to trick you in the sense that your patient probably shouldn't be getting this drug. So you have to remember that it inhibits dihydrofolate reductase, which is essentially folic acid, right? It's going to affect folic acid, and it's contraindicated in pregnancy due to teratogenicity, very obviously. Something that's not so obvious, however, is hepatotoxicity. you need to continually monitor liver function enzymes when a patient is started on methotrexate. Additionally, megaloblastic anemia can develop, myelosuppression, pancytopenia, so you really want to avoid this in HIV and AIDS patients. You can also see mucositis with long-term use, so that's just something to be aware of. Okay, on to osteoarthritis. So when it comes to osteoarthritis, we're going to have the PIP and DIP, as well as the first carpometacarpal joint involved. Again, I'll show you pictures of these in just a second. The PIP is going to be the Bouchard, DIP is the Heberden. Okay, and we have asymmetric joint involvement. You have to remember osteoarthritis is a wear and tear type of arthritis. It's the most common form of arthritis. And so obviously over time, we don't use our joints evenly. Of course, as we age, we might find that we put more weight on one joint or we play sports on one joint. If we're jumping in basketball or something, we wear on one joint more than the other. That's just one way you should think about osteoarthritis when you're comparing it to RA. Again, you'll have morning stiffness, but this one actually worsens with activity and improves with rest. So that's another way you can differentiate OA to RA. Risk factors are obesity, more weight on your joints, female sex, and you typically want to recommend weight loss. That oftentimes comes up in practice questions. It's associated with leg-calf-Perth disease, which is a really bad disease you'll see in children where the femoral head essentially loses blood flow. Those children, almost 30 to 50% of them develop progressive osteoarthritis in adulthood. So that's just something to note. Lumbar stenosis is also associated with osteoarthritis. And this is what I call the shopping cart arthritis. If you imagine somebody leaning forward, that resolves their pain. And so lumbar stenosis is very strongly associated with OA. Now, subchondral sclerosis on X-ray, which I'll show you, narrowing joint space, osteophytes, this is just better shown than talked about. Cervical spondylosis due to osteophytes can result in radiculopathy. That's another thing. Now, when you aspirate synovial fluid, you will not have elevated white blood cells. It'll be normal. And enlarged joints, crepitus, and decreased range of motion are all very typical of osteoarthritis. So treatments: NSAIDs, ibuprofen, celecoxib, exercises, intra-articular glucocorticoids, and then surgery. All right, so here we have the DIP involved. So these are the Heberden nodes. Okay, this is one of those examples. You will not see this in RA. And here you can see the subchondral sclerosis happening, as well as joint narrowing. And we have some osteophytes over here at the edges. Okay, and this is just another graphic showing you what happens over time with osteoarthritis. Again, be careful. They'll try to trick you. They'll give you a very obvious case of osteoarthritis. However, you don't want to have these patients on NSAIDs for too long because of ulcers and gastritis. So you really want to read your questions before you answer. The patient can often have epigastric pain. You probably want to evaluate them for ulcers first. Renal toxicity, very obvious one. Third trimester of pregnancy, again, don't give them NSAIDs. Okay, here's a typical practice question. You'll probably know it because we just went over it, but there are some things I just want to point out. Okay, so a 57-year-old software engineer presents with worsening joint pains, especially in the hands and fingers. He experiences stiffness in the morning, difficulty with basic tasks such as buttoning his shirt, and fatigue with weight loss over the past 6 months. Physical exam reveals mild swelling and tenderness in the metacarpal phalangeal and proximal interphalangeal joints. So that's already one cue right there. Laboratory results show an elevated ESR, and rheumatoid factor and anti-nuclear antibody are negative. So what is the most appropriate next step in evaluating this patient? You can pause the video for a second and see if you want to try to figure this out. So the answer is actually A, test for anti-CCP, which is the most specific antibody for RA. Okay, we have to remember that rheumatoid factor, although it is a part of RA, it can be negative because it's not exactly a specific factor we need to be looking for. Okay, but the MCP and PIP joint involvement is something you need to be aware of. Morning stiffness again. And he's also in the typical age group for developing RA. Okay, here's another practice question. A 68-year-old woman presents with progressively worsening right knee pain that she has had for 2 years. The pain exacerbated in the evening, initially responded to over-the-counter analgesics, but gradually lost effectiveness. There is no history of joint trauma. The patient recently retired as a janitor, has a BMI of 34, and shows tenderness over the medial tibial condyle with a small joint effusion. Range of motion elicits crepitus. What's the most likely diagnosis? I'll let you pause for a second and try to figure that out. So the answer here is, of course, osteoarthritis. So she's in the typical age group for osteoarthritis. She's had it for 2 years, exacerbated in the evening, not in the morning, because osteoarthritis worsens with activity. And the analgesics she was using gradually lost effectiveness. She has a BMI of 34. She's, obese. She's in that range, which is one of those risk factors. And she has tenderness over the medial tibial condyle with a small joint effusion. So this might made you want to think patellofemoral pain syndrome, right? But we have some other factors here, such as bony crepitus. That, along with the obesity in her age group and the length of her problems she's having, it's really going to be you're gearing towards this osteoarthritis. All right. So that's all I've got for you on this episode. Thanks for tuning in.